Diabetes cure is a completely inappropriate term. But cure often means that the patient is absolutely normal. Everything has gone, right? There is no chance of the disease ever coming back. So there is clearly no cure for type 2 diabetes or for any form of diabetes. Reversal, however, means that the glucose levels have normalized, but there is no further support needed. So it means that the patient is completely off the radar, right? Patient does not need to visit a doctor. Patient does not need to maintain any lifestyle measures, etc., which is not true. When you are in a state of remission, you are in that state at that moment of time, but does not mean that that's the state which is permanent. A patient with diabetes is like a cancer, where the patient is either in an active cancer state or is in a remission state, and from a remission state can go into relapse state. Same thing happens with diabetes.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, everyone, and welcome to this very interesting session. And thank you to Medflix for having me for this session. We are going to talk about something very, very important, extremely in vogue these days. There's a lot of discussion on this. There's a lot of myths about this, and there's a lot of patient interest in this topic. So that is what we're going to discuss. There's a lot of interest from the medical community also to try and understand what exactly is diabetes remission. Now, you would have heard this artist with other names, like some people call it diabetes reversal. Some people hai ke diabetes chudwa denge, whatever name you want to give. The point is that the correct terminology to use is diabetes remission. So in this next half an hour, 40 minutes, we are going to discuss everything in detail there is to know about diabetes remission. I'll also tell you some personal perspectives as well as evidence-based perspective on this entire topic. And by end of this enter this lecture, I really hope that you would be well versed with the entire topic of diabetes remission, and then you'll be able to give your patients a better feedback in terms of the questions which they ask about this very important topic. So let's start. So let's first start with what's in the name. Should you call it remission? Should you call it reverse? Or should you call it cure? Well, again, just a word here. We have this presentation uploaded on Gamma. Gamma is the new AI app for making presentations. So you can use this QR code to follow the presentation on Gamma as well. So that in case you miss out any point, you can go back and review that. Okay, so let's come back to the topic which we're discussing. What is in the name? Would you call it remission? Would you call it cure? Would you call it reversal? So first and foremost, diabetes cure is completely inappropriate term. But cure often means that the patient is absolutely normal. Everything has gone, right? There is no chance of the disease ever coming back. So there is clearly no cure for type 2 diabetes or for any form of diabetes. However, the term which is interchangeably used, and a lot of people use this term colloquially also, is remission versus reversal. And the scientific community, the endocrine community, the diabetes community prefers to use the term remission instead of reversal, and we'll tell you why. Now, remission basically means that there is need for ongoing support to prevent the patient going to relapse. The corollary to this is what you see in oncology. I'll come to this in a few minutes. Also, it also means that there is a continued efforts required from the patient side, right? There is continued changes in lifestyle which are required and continuous monitoring which is required. Reversal, however, means that the glucose levels have normalized, but there is no further support needed. So it means that the patient is completely off the radar, right? Patient does not need to visit a doctor. Patient does not need to maintain any lifestyle measures, etc., which is not true, as you'll learn from this entire situation at the end of the presentation. This is rarely achievable. The reversal state does not happen in normal human beings with type 2 diabetes, right? It does not happen. So the correct terminology is to use is diabetes remission and not reversal or cure. Okay, so these are wrong terms to use. Now, let me give you two corollaries to this to understand this situation better. One is a very fundamental point, right? Think of it as a state of matter, right? So if you see water, in a liquid state, it's water. In a solid state, it's ice. In a gaseous state, it's steam. So it changes from one state of matter to the other, right? So these states are, well, to some extent stable, but it can change depending on the temperature, depending on the situation. For example, if you have water in the solid state, which is ice, and if you allow it to melt, it goes back into the liquid state. Same thing happens with diabetes remission. And we're going to discuss this when we discuss the pathophysiology of why this happens. But what you have to understand is when you are in a state of remission, you are in that state at that moment of time, but does not mean that that's the state which is permanent. Water does not remain permanently in ice state, does not remain permanently in steam state, does not remain in liquid state permanently. The state keeps changing. So the same way, a patient who is currently in diabetes remission need not remain in remission all the time. The patient who is in a full-blown diabetes need not remain in full-blown diabetes and can go back to remission. So this is very similar to what happens in cancer. So in cancer, a lot of cancers, there are cancers where you say that the patient is cured from cancer. But in a lot of cancers, especially hematological cancers, we often say patient is in remission. A patient has leukemia, patient you give them chemotherapy, patient has now gone into remission from leukemia. That means that currently the patient is out of danger, but does not mean that the patient does not require regular monitoring, does not require regular cure, or in fact may require some sort of treatment also on a regular basis. But as of now, the patient is out of danger. In some state, maybe the situation can go back into a relapse, and when the patient goes into a relapse, the patient goes back into where the situation was already. So what you have to really see a patient with diabetes is like a cancer, where the patient is either in an active cancer state or it is in a remission state, and from a remission state can go into relapse state. Same thing happens with diabetes. So that is something you have to really understand and really kind of take into account. So what exactly is diabetes remission? What is the definition of diabetes remission? Now, for the purpose of standardization, American Diabetes Association in 2021 consensus actually gave a very clear definition of diabetes remission. This is clear. This is a consensus. This is being agreed upon by all the specialists across the world. Now, by definition, diabetes remission means that there are three situations which has to be fulfilled. One is that the HbA1c should be less than 6.5%. This same situation should be maintained for 3 months. And if you talk about medications, and this is where the importance lies, the patient should not be on any medication which is a glucose lowering pharmacotherapy. So this is the current definition of remission. So again, I repeat, HbA1c should be less than 6.5%. The duration of this HbA1c less than 6.5 should be at least 3 months, and the patient should not be on any medication. Now you'll ask me very interesting questions. For example, let's say my patient is on empagliflozin, which is being prescribed for heart failure. Now we all know that empagliflozin can be prescribed for heart failure, can also be prescribed for diabetes. Now, patient on empagliflozin is having HbA1c of 6%, and he or she is maintaining this HbA1c of 6% since the last 3 months. Is the patient said to be in remission? Answer is no. So, by definition, empagliflozin is still a glucose lowering medication, and because the patient is on a glucose lowering medication, even though the intended purpose is heart failure, though the patient is on this medication, the patient is not said to be in remission. So, such patient would not be considered in remission. Okay. So that's a very important thing you have to understand, that the patient should not be on any medication that is considered a glucose lowering therapy, even though it is not intended for the purpose of glucose lowering. It is intended for some other purpose, but he or she should not be on those medications. And then and only then would you say that the patient is in remission. So, like I said, the key components are HbA1c should be less than 6.5%. In certain situations, if you are not able to get the HbA1c, you can also use fasting blood plasma glucose as a corollary. And if the fasting plasma glucose is less than 126 milligram per deciliter, the same can be considered as an alternative if HbA1c is not reliable. Same thing, the target should be there. It should be there for at least 3 months, and patient should not be on any glucose lowering medication. Now, why this point again of remission really comes, that if the patient has maintained this situation, it does not, and I repeat, it does not mean that the patient does not have to see the doctor. It does not mean that the patient does not have to be screened for diabetes related complications. Now, what are the complications that we usually screen a patient with diabetes for? So we screen these patients for kidney involvement, that is with a urine albumin creat ratio. We screen this patient for diabetic retinopathy. We screen this patient for heart disease. So all these things have to be regular screened for. We often look at the foot, we often look for UTI, we often look for any other infection, right? So we often keep screening and keep monitoring these patients. I'm sorry, keep monitoring these patients. And even if the patient is in a state of remission, the monitoring has to be continued. Okay, so that's a very important point. And remission does not mean that the patient tata goodbye. You don't ever see the patient again. Patient does not have to see you again. That's not true. The patient has to see you, and you need to see the patient at a regular basis to prevent the patient from developing these complications. Now let's come to this situation, and this is something very important. And this is what now I often see a public discourse in social media about diabetes remission. People often talk about complete nonsense. I've seen people talk about things which they have no idea of what they're really speaking about, right? First, you have to understand that all types of diabetes cannot go into remission. Some types of diabetes can have remission, some type cannot have remission. For example, there are certain types of diabetes which are naturally remitting. Like for example, if a patient is on a steroid, so patient is having a HbA1c which is let's say 6%, a patient is in a pre-diabetic state, and you give this patient glucocorticoids or steroids, and the patient's blood sugar goes up. For example, we currently have a patient in ICU who is having a raised ICT. The patient had an HbA1c of 5.9%. Patient was given a dexamethasone. Patient's blood sugar went to 200. Right. So by definition, the patient is having diabetes or hyperglycemia. But is this permanent? No. So when you reduce the dose of dexamethasone, the patient's blood sugar can normalize. So any form of drug-induced diabetes or certain steroid-induced diabetes or glucocorticoid-induced diabetes can be naturally remitting, because once you stop this offending drug, the patient goes back into a state of normoglycemia. Second is gestational diabetes. We all know by definition, gestational diabetes is when the pregnant lady develops hyperglycemia, but after delivery, the blood sugar becomes normal, and that is often again a naturally remitting form of diabetes. And certain patients, as you had seen in the time of COVID, there are a lot of patients who develop very severe hyperglycemia during COVID because of the COVID virus and because of other reasons, including because of steroids and even remdesivir. So such patients were having what is known as hospital hyperglycemia. This is something which we see day in, day out in our hospitals as well. Hospital hyperglycemia, also known as stress hyperglycemia, is often transient and can often go back to a naturally remitting state after the patient is cured from whatever infection or whatever disease that the patient is having, and the patient goes back into a normal state. Again, the hyperglycemia can reverse. So these are all naturally remitting forms of diabetes, right, which are naturally seen in state, right? However, having said that, if a patient develops hyperglycemia after giving steroids, or a patient develops hyperglycemia during pregnancy, which is gestational diabetes, this is like a natural stress test for pancreas. And such patients, sorry, I'm having a little bit of viral infection, so pardon my cough. So this type of situation is a natural stress test for pancreas. Okay, so a patient who develops hyperglycemia after giving steroids is likely to develop diabetes in future. A patient who develops gestational diabetes is very likely to develop diabetes in future if she does not take care of her, lifestyles at a later date. So, if you identify a patient who develops hyperglycemia in this naturally remitting forms of diabetes, it's very important that you re-emphasize the lifestyle and again monitor this patient, because they are likely to develop diabetes in future. Then, of course, there are certain types of diabetes which can undergo remission. For example, type 2 diabetes, or diabetes that happen because of certain endocrine disorders. For example, patient has acromegaly and you have done the surgery, you have done the pituitary surgery, acromegaly is cured, the patient goes into remission. Patient has thyrotoxicosis, which is induced hyperglycemia, again that can go into remission. Pheochromocytoma also can cause hyperglycemia, again that can go into remission. Cushing syndrome can produce hyperglycemia, can go into remission. So these are all situations where the patient can go back into remission after the endocrine disorder has been cured. But there are certain forms of diabetes which cannot undergo remission as of now, as of what we understand in 2025. There is a lot of research going on to get a type 1 diabetes into remission, but as of now, there is no data. All right, there are just some emerging studies, but mostly there is no permanent remission for type 1 diabetes. So type 1 diabetes being an autoimmune disease, there is no remission, and a patient with type 1 diabetes requires lifelong insulin therapy. Whether the patient likes it or not, that's the reality. A lot of pancreatic diabetes, there are certain, early forms of pancreatic diabetes which can undergo remission, but most cases generally no. So in most cases, pancreatic diabetes does not undergo remission, and such patients again have to be, kind of more or less permanent forms of diabetes. And then there are certain forms of monogenic diabetes or MODI, which again may not undergo remission. And again, these patients again may have permanent forms of diabetes. So these are all forms of diabetes which generally do not undergo remission and have to be monitored. As of 2025, we don't have much data about remission in these cases. And all we have is that these patients probably have permanent forms of diabetes. So even amongst type 2 diabetes, all patients are not likely to develop remission. There are certain patients who are more likely to develop remission, and there are certain patients who are less likely to develop remission. We'll discuss this. This is a very important thing, and we'll discuss this in more detail to identify patients who are more likely to develop remission. But generally speaking, and this has been from my experience, so this slide, completely consider this slide as an expert opinion rather than from any data. We are going to show you data at a later date, but from expert opinion point of view, what we are seeing is that young patient with good residual beta cell can go into remission. A patient who presents in a ketosis prone diabetes, so or what is known as a flat push diabetes. So such patients suddenly present with very severe very high blood sugar with forms of relative insulin deficiency. And then after, if you give them insulin, these patients, the blood sugar improves and the patient can go into a state of a sort of a remission. Obese type 2 diabetic patients also tend to go and have a more likely to develop remission. And those with NFLD or fatty pancreas also can develop remission. Having said that, a very interesting point. Now, type 1 diabetes also has a naturally remitting form of situation called, right, honeymoon period. Right? I'm sure you heard about this. So a type 1 diabetes honeymoon phase, a type 1 diabetes also naturally sometimes goes into remission. Of course, this period is undefined. It can, the definition of remission requires at least 3 months of period. Honeymoon phase can last anywhere between few weeks to months. And I've seen a patient in years also in honeymoon phase. So honeymoon phase can happen. There could be a transient remission which can happen with type 1 diabetes, but again, this is not permanent. And this again, patient goes back into the same situation which they have, right? So in the same light, there are certain type 2 diabetes patients who present in a more aggressive manner, who present with ketosis, who present with very severe hyperglycemia and relative insulin deficiency. And then once you treat them with insulin, they go into a state of a honeymoon phase type of situation. And this honeymoon phase in such patients, if they're careful, if they're able to maintain good glycemic control and monitor the lifestyle measures, these patients tend to remain in that situation for a long time. In fact, even I've seen patients for years together, these type of patients who maintain remission. I think this is the most important type of patients who actually are likely to develop remission, and these are the patients we really need to closely monitor. Then there are patients who have NAFLD or fatty pancreas, right? So these patients also, what I've observed is that if the fatty pancreas and the fatty liver reverses, again, if they reduce a lot of weight, such patients also are likely to go into remission. And in fact, if you talk about Roy Taylor's work, the direct study, most of the work has been done in such type of patients who tend to have ectopic fat and who tend to go into remission. Okay, so we have developed this small little mini application which can help you predict which patients are likely to develop remission. So we have called it a Mohan Taylor Lakhani, that's me, tool for diabetes remission. Please note certain caveats. This is not clinically validated. Okay, so not a clinically validated tool. This is just a you can say an open source experiment, right? There is a QR code I've given. You can scan this QR code to see how this tool really works. If I can show the video. Yeah, so here's the video. So this is what the screen looks like, right? So here, in this situation, what you have to do is, you have to enter the patient's data. Just mind you, there are certain investigations you'll require in such patients. You'll require a lipid profile. You'll require to measure the waist circumference apart from the weight and height. And you also require to look at the patient's mixed meal stimulation test, where you have to do a C-peptide in fasting and C-peptide post-meal. Okay, so let's enter the patient's data. So this is a patient who is 40-year-old, HbA1c 7.5. The weight is 96 kg, height is 178. Waist circumference, let's say, is, you have to enter this in centimeters, so let's say 100 centimeters. Triglyceride is this much, 258. Let's say HDL cholesterol is 42. And you take the C-peptides, let's say C-peptide value is 2.3 fasting and it is 8.6 post-meal. So here it will check for the eligibility for remission. It calculates the BMI. It calculates the mixed meal score. Again, this is a not clinically validated score which is developed by us. And then it looks at whether type 1 diabetes is ruled out or not. So remember, type 1 does not go into remission. So we rule that out first. And then it says that it belongs into the cluster. Now, there is a cluster classification which is done by Dr. Mohan. That's why we have named this tool after Dr. Mohan, right? So we looked at this cluster, and there are certain clusters which are likely to develop remission. So this patient goes into cluster 3, which is combined insulin resistance and insulin deficiency, and such patients are less likely to go into remission. So again, such patients are not going into remission, and this remission criteria is not met, right? However, if the patient is in a certain different cluster, patient is likely to undergo remission, and hence, we have selected certain clusters again based on Dr. Mohan's data to show that which patients are likely to go into remission and which patients are not. Again, couple of things I'll just repeat. This is not a clinically validated tool. Yeah. So sorry, I think I got disconnected. So I was showing you the diabetes remission tool. So just a few caveats here. The diabetes remission tool, one, it is only applicable for newly diagnosed patient with diabetes. Second caveat, which is of course equally important, which is that this is not clinically validated. Okay, so this is just an open source idea, and I kind of, if anybody interested in developing this further, please feel free to do that, right? So that's the whole point. Okay, so this is the mini application which we kind of developed. You can scan the QR code and have a look at this, right? Moving on, there are other alternative definitions for diabetes remission. So this is Dr. Kalra's work, right? So Dr. Sanjay Kalra had given some alternative definitions which can be used for diabetes remission. So, for example, he says metabolic remissions. Metabolic remission is a situation where there is reversal of insulin secretory defect or insulin resistance. So, if the patient had insulin deficiency, if that gets corrected, or if the patient has insulin resistance, that reduces, that is metabolic remission. He talked about clinical or partial remission. That is, you achieve an HbA1c below an individual set point. That can be considered a clinical remission or a partial remission. There could be biochemical or complete remission in which the HbA1c reaches the threshold value, which is actually HbA1c of less than 6.5%. And he talks about pharmacological remission, where there is absence of requirement of any drug therapy. So these are all alternative partial definitions for diabetes remission. So we, of course, go with the strict definition, which we talked about in ADA's definition, but these are all alternative definitions which we can use. Then, of course, there are other people who have given some other forms of remission, where they talked about the duration of remission. So they say transient remission, when the normal glycemia persists for 3 to 6 months. They talk about short-term remission, when it's between 6 months to 1 year. Long-term remission, when the patient maintains remission for 1 to 5 years, and prolonged remission, when the patient has remission for more than 5 years. So the duration also is now correlated with some sort of terminology which is used for these forms of remission. Now let's come to the very important area, that is the physiology of remission and how remission happens and why remission happens. Now, since you are on the Medflix platform, I suggest that we had this talk on on a pathophysiology of diabetes, and I talked about a unifying theory for pathophysiology of diabetes. I think you might be able to find it on one of the older lectures on Medflix. Here we have discussed this particular concept in more detail, but I'm going to talk about it again here. So what you have to understand is very fundamentally, very importantly, right, that diabetes basically is in a state of like a balance. Okay, so it's like a balance. Okay, so on one hand of the balance, on one side of the balance, you have insulin resistance, and on one side you have the insulin production. Okay, so you have insulin resistance and insulin production. So this is the balance in the equation, right? So all forms of diabetes, any form of diabetes, when the balance between insulin resistance and insulin production is mismatched, that is when that leads to hyperglycemia. For example, if you talk about type 1 diabetes, okay, so let's talk about type 1 diabetes first, right? Okay, so in type 1 diabetes, insulin resistance is not a problem. The problem is beta cell function. So because of autoimmune destruction of the pancreas, the beta cells, the insulin is not produced enough. So because, again, see, insulin resistance, the insulin production. Okay, now insulin resistance is static, but insulin production has gone down. Because insulin production has gone down, there is a mismatch and there is type 1 diabetes. Then let's say same thing happens with pancreatic diabetes. So pancreatic diabetes, again, the insulin production and insulin resistance is initially matched. Now the patient undergoes pancreatitis, right, or has chronic pancreatitis, and the insulin production goes down. Insulin resistance may remain the same, slightly increase, and this misbalance, right, leads to pancreatic diabetes. What happens in type 2 diabetes? Now hear me out what happens, right? So let's say this is insulin resistance and this is insulin production. Initially, what happens is the patient starts gaining weight and starts having increase of insulin resistance, right? So insulin resistance keeps increasing. Now, what does the body do? To compensate for the increased insulin resistance, it starts producing more insulin. So it keeps maintaining a balance. So insulin resistance keeps increasing, insulin production keeps increasing to match the insulin resistance. Now, this goes on for many years. This is the situation where the patient is in a metabolic syndrome, or patient is in a pre-diabetic state. These are typically patients who have HbA1c of 5.9, 6.1, right? And what is really happening here is, and these patients also have acanthosis nigricans, their triglyceride levels will be very high, they'll have fatty liver. So these are the patients where there is increased insulin resistance, and there is increased insulin production to match the insulin resistance. Now, these patients, these are the best thing, if you want to form any kind of long-term changes to the patient, this is the state where you should intervene, right? Where what you do is with lifestyle measures to reduce the insulin resistance, and then naturally that gives more rest to the beta cells, and also the insulin production also eventually stabilizes. So these patients have to be, taken to task much early, right? Even before the HbA1c goes above 6.5%. However, if this situation is not taken care of and this keeps increasing, there comes a situation where there comes a point where the insulin resistance is still high, but the insulin production is not able to match the insulin resistance. And that is where there is a relative beta cell dysfunction. And this progressively worsens, produces a vicious cycle because of the glucotoxicity, and this produces an imbalance. And that is when a type 2 diabetes patient is diagnosed with type 2 diabetes. Okay. So this is the fundamental point, right? Now, right at the time of diagnosis, remember, this is a question which was often asked to us in endocrinology also. Even type 2 diabetes is a disease of reduced insulin production by the beta cells. Even though insulin resistance is the primary pathophysiology, the pathophysiology that actually defines the disease is the beta cell production of insulin. So even in type 2 diabetes, at the time of diagnosis, the patient has lost about 60% of its ability to produce insulin. Now, the question is, what can you do? So again, if you are in a situation where you are in a negotiating situation, right, in our patient with type 2. Okay, so let me just draw this for you. Okay. So in a type 2 diabetes, insulin resistance is high, insulin production is not able to match up. So what you have to do is you have to meet midway. You have to reduce insulin resistance and slightly increase insulin production as much as possible. Now, that is why early, right, a patient who is earlier in the phase of the disease is more likely to benefit. I'll exactly tell you why. So it is taken that insulin resistance has to be brought down, right? Now, let's say this is the equilibrium state. So you have to bring down insulin resistance. The more work has to be done to reduce insulin resistance. But a lot of times what happens is, especially in early diagnosed diabetes, there are some residual beta cell function which can be salvaged. So, and this basically what happens is, the patient initially when they present with glucotoxicity. Okay. So during glucotoxicity, there are some beta cells which are salvageable, which also get stunned, and this stunned beta cell cannot produce insulin as it should. So if you reduce the blood sugar, this salvageable beta cell, which comports very small amount of it, let's say 5 to 10% of beta cell, these beta cells can be salvaged and you can actually improve insulin production also. However, this situation is not possible for long-standing diabetes, right? So that's why a patient who's having diabetes for a long time, and typically I'll tell you, if it's more than 10 years, more than a decade, very unlikely that the patient is going to go under remission, because the beta cell production is so poor that you have to reduce insulin resistance very severely to really match the insulin production. So long-standing diabetes, more than 1 decade, it is very unlikely that the patient is likely to undergo remission. More than 5 years also, right? If the disease has been around, less likely, right? However, for a highly motivated patient, that is also possible. But more than a decade of diabetes, it's very unlikely that the patient is likely to undergo remission, because no matter how much insulin resistance you are going to do, the insulin production is so poor that you are never able to match that insulin resistance, right? So this is a very important physiological point to understand, that to bring the patient into the equilibrium state, you have to reduce the insulin resistance as much as possible. And in some cases, you can salvage a little bit of insulin production, right? Which you can leverage, especially early in the disease, right? And then you reach a equilibrium state. And this equilibrium state is when the patient goes into remission, right? Now, the same thing. The same thing was what Dr. Roy Taylor has very eloquently described in his twin cycle hypothesis, right? So this is the fundamental which he used in his primary research work, which is the direct trial. In fact, the most respectable trial for diabetes remission is the direct trial. We'll talk about the direct trial in a few while. So what he said is, he said something very simple. He said that type 2 diabetes, and if you understand diabetes now, right, it's very important to understand that type 2 diabetes, there are two cycles you have to understand, right? One is in the liver, other is in the pancreas. Okay, so type 2 diabetes is a disease of primarily liver and pancreas. Now, both cases there is ectopic fat which is deposited. Okay, so there is fat deposited in the pancreas, and there is fat deposited in the liver. Now, the ectopic fat present in the liver produces central insulin resistance. Okay, the fat which is deposited in the pancreas leads to what is known as fatty pancreatic disease, which leads to reduced beta cell function. Right? So the beta cell function is reduced because of the fat in the pancreas. And hear this very carefully. So the ectopic fat in the liver produces central insulin resistance, and the fat in the pancreas leads to reduced beta cell function. So what you have to do? You have to reduce both these fats, right? You have to reduce the fat in both the liver and pancreas. So this is where he proposed the theory of the twin cycle. Okay. So what he said was something very simple. He said you have to reduce the fat in these two organs. Now, of course, this is a simplified, oversimplified version, because the fat, though primarily the liver fat is very important and pancreatic fat is very important, there is also fat in the muscles. Okay, there is ectopic fat in the muscle which leads to peripheral insulin resistance. There is adipocytes which also contributes, which is, there is a lot of contribution of that as well, right? There is also fat which is present near the cardiac muscle, right, which is the pericardial fat, and you have the fat in the kidneys, right, the renal sinus fat. So all these fats contribute to insulin resistance. At the same time, they also contribute to the complications that you see with diabetes. There is visceral fat also. So all these fat ultimately contribute to the diabetes. However, the liver fat is something which is very important, because liver fat you can actually measure, right? Liver fat is something you can actually visualize, right? And hence liver fat is something which is very good to monitor. Now, how do you reduce this ectopic fat? So to reduce this ectopic fat, currently the only strategy is to reduce the fat overall. So overall, you lead to weight reduction, you lead to fat reduction, and this overall reduction of fat reduces the fat in all the areas: fat in the liver, fat in the pancreas, fat in the muscles, fat in the adipocytes. All the fat which is there, it reduces, and because all this fat is reduced, ultimately the patient goes into a state of remission. So fundamentally, for type 2 diabetes to undergo remission, there is only one strategy as of now. Let me put it in big words: weight loss. There is only one way in which you can undergo diabetes. There are a lot of people who will come and tell you fancy things. Don't listen to fancy things. Only one thing you have to understand: there is only one strategy that leads to diabetes remission in type 2 diabetes, and that is weight loss. If you reduce the weight, you reduce the pancreatic fat, which improves the beta cell function. You reduce the central insulin resistance by reducing the fat in the liver. You reduce the fat in the pancreas, reduce the fat in the liver. Completes the twin cycles of Dr. Roy. You also reduce the fat in the muscles, right? You also reduce the fat in the cardiac, reduces the cardiovascular risk, and reduces the fat in the kidney, also reducing the renal risk. So all these things ultimately is what leads to the diabetes remission, and also remission from diabetes related complications. Okay? So this is a very important fundamental thing. So then comes how you will achieve remission. And this is exactly what I told you. The main way is weight loss. So you can see in all these things, right, except for one which I discussed, all the first four strategies which I said is related to weight loss. So weight loss by lifestyle measures, weight loss by meal replacement. This is what was done in direct study. Weight loss with newer agents like GLP-1 RA or other drugs. Weight loss with bariatric surgery. And one alternate strategy is early intensive insulin therapy. Right? This is something separate. So we'll discuss this in more detail in separate. Right? But the first four strategies ultimately involve weight loss. Okay. So now weight loss leading to diabetes remission is not a new thing. Weight loss has led to remission of many other metabolic disorders, which we all know very well. For example, PCOS. PCOS, it's very well known that modest weight loss about 2 to 5% improves menstrual irregularities and improves fertility outcomes. And often, if the patient has significant weight loss, about 10%, the entire PCOS goes into remission. Okay, so this has already been established in other conditions like PCOS. Another condition where it is very well established is non-alcoholic fatty liver disease, right? Where 7% weight loss leads to remission from fatty liver, right? Similarly, the same thing is now known with type 2 diabetes also. How much weight loss leads to remission differs, but generally speaking, if you take the data from Dr. Roy Taylor's study, Dr. Roy Taylor has shown that 10 to 15% weight loss ultimately leads to diabetes remission. So for diabetes remission, probably the safe point is to target 15% weight loss. And this 15% weight loss ultimately has direct correlation with remission. So the proven strategy for type 2 diabetes remission is weight loss. This has been clinically proven across multiple studies, including bariatric surgery, including other medications and other things. Right? So what you should do, if you want to just target the metabolic improvements, look at 5 to 10% weight loss. But if you are then looking at more complications and want to reduce diabetes and reverse diabetes, as a lot of people call it, then you have to look at 10 to 15% weight loss. And 10 to 15% weight loss is the weight loss which you should target if you want to get away from all these complications. Now, of course, there could be individual variation. Some people will develop diabetes remission with a lower weight loss. Some people will require more weight loss. So there is a spectrum. However, having said that, if you see Roy Taylor's work, 15% generally leads to remission in 90%. So it's that amount of weight is probably good. However, of course, you have to understand that the duration of diabetes and the other factors also come into picture, and one size cannot fit all. So you have to, there will be, quite literally one size cannot fit all. So there is individual variation in this response. Okay, so this is the direct study. Let's look at some studies, right? So if you look at the direct study, so this is the most, I think, probably the fundamental study which brought the talk about diabetes remission into picture. So direct study was done in England, right, by Dr. Roy Taylor and his group. It was published in the Lancet, as I believe, and I think it was published in some aspects of it published in NEJM as well. So what they used was, basically, it was a meal replacement strategy, right? What they did was meal replacement, right? So it's not, a lot of people say that, oh, ye kar denge, wo kar denge. No, it was a meal replacement strategy. So they actually took a form of a liquid meal, right? Pre-prepared protein shakes. These protein shakes were given to the patient in place of the meals, and this meal replacement is what led to diabetes remission. Okay. So the key findings, right? The duration of the study, the initial trial was 2 years. They found that at 12 months, 46% of the intervention group achieved remission, and 36% at the end of 24 months maintained remission. Right. So again, the remission criteria was 6.5% without anti-diabetes medication for 2 months. However, now the definition is 2 to 3 months. But let's take this with a pinch of salt and say that, okay, 2-3 months is fine, right? So ultimately, whatever it is, that's fine. And as said earlier, weight loss was the main predictor of diabetes remission. Now, if you see the trial in more detail, what factors led to more remission? Most significant factor for remission was weight loss, and those who had more than 15 kgs of weight loss, which is again close to 15%, and 86% of these were who had more than 15 kg weight loss at remission. So like I said, 90%, 15% if you lose weight, 80 to 90% you are likely to develop remission. So weight loss was the strongest indicator in this direct study. There are certain baseline characteristics which, of course, were associated with remission. For example, fewer anti-diabetic medication, lower triglyceride and GGT levels. That means that these patients had lower liver fat. Okay, so those patients with lower liver fat actually had, this is an indirect marker of that. Lower liver fat had better chance of remission. Better quality of life, people with less anxiety, depression were more likely to develop remission. Lower baseline HbA1c, which is needless to say, and at 12 months. So if they, in the initial 1 year, if they are able to, have better kind of reduction of HbA1c, they are more likely to go into remission. Remember, it's a 2-year trial. And older age and male sex had more likelihood of remission, which is again contrary to what we used to think, that younger patients are probably more likely. But there might be other factors also into play here. What factors were negatively linked with remission? So early weight loss, positive and negative factors. So early weight loss led to more remission, and higher program attendance led to more remission. But use of antidepressant, patients with anxiety, higher triglyceride, GGT, some weight regain after weight loss, all these had more negative consequences, and these were less likely to be associated with remission. Now, after looking at Dr. Roy Taylor's study, NHS actually funded a program, which is the NHS T2DR program for diabetes remission. They have looked at a similar strategy for diabetes remission, and this is the detail. You can find the details of the same. Some early initial 12-month period, they actually found 27% of the patients with complete data who achieved remission, and 32% of the patients of program completers achieved remission. So they also found about 30% of patients achieving remission at 1 year. Now, so again, here they've used 3 months as a criteria. Okay. However, of course, this is again early. They are doing some follow-up studies, right? So probably need to see what really happens to these patients in future. Okay. Then, of course, there are studies done from India, and in the only notable study which have looked at these things very scientifically is the company called Twin Health, which has looked at this digital twin technology for diabetes remission. It's a very simple thing they've done. Is make it sound very complex, but it's very simple. What they do is they take, put all variables and sensors for you, and then after the sensors and variables, they take certain data from that, and based on the data, so they'll ask you to wear an Apple Watch, they'll ask you to wear a CGM, they'll ask you to wear, a sleep apnea monitoring device. So all these things, their data they'll collect, and after this data, they'll create a digital twin model for you. And what they'll do is they'll see what interventions are going to work for your digital twin model. So that's the ultimate, idea. The good part is that they are looking at this scientifically rather than trying to just make money out or quick buck out of it, which is good. It's an expensive program, but at least they are looking at from a scientific perspective. So what they found was, there were a lot of patients where they had 74% reduction in anti-diabetic medication use. However, remission was not that great. The use of anti-diabetics was more of a thing which they really looked at, which I think is again a little soft target, but fine. I mean, it's fine. They mainly looked at extraglycemic improvements also, which they saw, right? And they found that there was reduction in blood pressure, HSCRP, triglycerides, NAFLD scores also, which is again expected with any form of data which has undergone any form of weight loss. Bariatric surgery, this is published, the SOS Swedish obese study, right? Again, 76% were free from diabetic medications at 2 years, and 5 years also 69% maintained remission. Again, a lot of patients actually sustained remission. So bariatric surgery is a very well established strategy for weight loss and very well established strategy for diabetes remission also. So a lot of patients, provided of course they don't regain the weight, can develop and maintain diabetes remission, which makes it a very attractive option for bariatric surgery. So I think it has a potential. However, of course, it will depend on the type of surgery which is done and a lot of other factors also. So what were the factors in the Swedish studies which led to remission? Duration of diabetes, again, shorter duration of diabetes had more remission. Patients not on insulin had more remission. Patient with lower HbA1c, higher C-peptide values, and lower leptin to fat mass had better likelihood of remissions. These are all the things that looked at. Of course, apart from the remission from diabetes, these patients also had reduction in microvascular as well as macrovascular complications, which makes it very attractive for the remission. Now, let's look at a completely alternative strategy for diabetes remission. And this idea, basically, this has been done in India also, right? Long time back, there's a study from the senior Dr. Sahai who looked at this it was published in Chapi. But this concept primarily comes from China. Right? And this Chinese concept is early intensive insulin therapy in newly diagnosed type 2 diabetes patients, which they say leads to some form of remission. Now, the idea here is very simple. And I think this is a very attractive option for Indian patients also, because from a pathophysiological perspective, a lot of the Chinese patients are very similar to Indian patients from a diabetes perspective, from a metabolic perspective. So what they did was, so you take a newly diagnosed patient with diabetes and you start them on multiple doses of insulin, right? Straight away start them on insulin. And then what you do is gradually you reduce the, give it, in this study, what they did was they gave insulin for 2 to 3 weeks, and then they stopped the insulin and the patient went into remission. And some patient actually maintained remission for almost a year, right? So 51%, right, was the remission rate, right? And in fact, in some cases they use insulin pump, right? So with insulin pump, 51% remission, with insulin multiple dose of insulin, 44% remission. And if you used oral anti-diabetics, there was 26% remission. So early intensive therapy led to diabetes remission. And that's why if you see any of my talks, I always say early intensive is the best way to prevent long-term complications, right? And how was this maintained? And there's a meta-analysis separately done, which said that at 3 months, 66% remission. As the time increases, the remission rate reduces. But even at 24 months, so these patients were just given insulin infusion or insulin, pump, and some of them actually maintained remission for almost 2 years. Now, here the fundamental concept I told you that you have to meet in the middle, right? So you reduce the insulin resistance or you improve the beta cell function. And here, in most of the cases where you are losing weight, you are reducing insulin resistance. But this is a situation where you're actually salvaging the beta cell function. So what you're doing is by giving insulin early, you're reducing the glucotoxicity, and by reducing the glucotoxicity, you are improving the beta cell function. This improvement in the beta cell function ultimately is what carries the patient for almost 1 or 2 years in terms of remission. So it's a very attractive idea, right? Just 2 weeks of intensive therapy, and your patient actually goes into a very good state for a long period of time, right? So there was improvement in HOMA beta, which is a marker of insulin production. Eventually, there was also reduction in insulin resistance, and the first phase insulin production was restored, and there was reduction in glucagon levels. So overall, there was significant improvement in the biological parameters also as far as the insulin therapy was concerned, right? What type of patients had remission? Shorter duration of diabetes. So again, patients with new onset of diabetes or early diabetes had more likely to develop remission. Again, patients with a better fasting plasma glucose, higher BMI patients actually had more likely to develop remission. Early first phase insulin secretion and lower need for long-term insulin therapy ultimately led to better remission. So these were the people who were more likely to develop remission, right? So this is the early intensive insulin therapy, right? So these are all strategies which you can do in terms of remission, right? So I think in this comprehensive lecture, we first talked about the definition. Again, let me repeat, the definition of diabetes remission is when you have the HbA1c less than 6.5% for at least 3 months, and the patient should not be on any anti-diabetic medication or glucose-lowering medication. Secondly, we talked about the pathophysiology and the physiology of diabetes remission, and where I talked about the balance between the insulin resistance and insulin production. And thirdly, we looked at the strategies for diabetes remission, where we looked at weight loss being the primary strategy for diabetes remission, and a weight loss of close to 15% or 50 kg, right? Whichever is higher is more likely to develop remission. Whether this is achieved by bariatric surgery or whether it's achieved by diet and lifestyle measures and meal replacement, it doesn't matter. But ultimately, that is what kind of combines. And then alternate strategy is the early intensive insulin therapy, which is proposed from China, where they found that especially newly diagnosed patients with diabetes, early on, if you give them insulin, the patient goes into a honeymoon state, which often lasts for about 1 to 2 years. So now let's look at the final few slides, where we'll talk about a summarized approach. And here, from now on, what you're going to see or what you're going to hear is mainly expert opinion, no clinic, no more science, more of my opinion, right, which I'm going to give. So what I said, and if you see the title, right, it was truth versus hype, right? But I've sort of re-christened the title to good, bad, and the ugly, right? So there are good aspects of this entire diabetes remission equation. There are bad aspects of it, and there are some really ugly aspects. Let's talk about the good aspect. I think it's very important that if the patient is motivated, I think the most important thing is if you tell, and I remember even before the direct trial, even before I still have that poster on my OPD, that type 2 diabetes can undergo remission, please talk to your endocrinologist about it. Still, that same poster is still there, pasted on my OPD, right? It's still around. This was almost 5 to 7 years back when we talked about this, thought about this, and actually wrote about it. Now, the good part is that this is highly motivating for the patient. So if you tell the patient that, you show them the light at the end of the tunnel, tell them that if you are good at lifestyle measures, if you are regular at, the targets which we give you, you can stop the medications and you don't have to be on medications for the rest of your life. Secondly, again, in terms of cost, and this is why NHS is really looking at this very closely, is that diabetes remission reduces the cost burden. Remember, the medication burden reduces, the complications reduce. So because complications reduce, the chances of, the risk, the cost burden because of the complications reduced. And very importantly, we are then focused on the core pathophysiology of the entire disease. Now, ultimately, we are looking at core pathophysiology because earlier, when I was a MBBS student or a MD student, it was all about sulfonylurea, de do, right? Which is completely wrong way of going about it. Now we have understand the basic pathophysiology, and now we actually deal with the pathophysiology because our patients tell us that I want to go into remission, and that's why give me drugs and give me medications which can change. And this is where I have said this. We have said I say a lot of things. Unfortunately, don't publish all of these things, right? But we have used this terms disease-modifying anti-diabetic drug, right? This terminology is basically what we are trying to say is that a patient, there are certain drugs like the SGLT2 inhibitors or like the GLP-1 receptor agonists, which modifies the disease process, and because of the modification of the disease process, this ultimately hits the core pathophysiology of type 2 diabetes and ultimately then leads to better long-term outcome. Don't take my word for it. This has widely been proven in multiple studies, right? So, I came up with this concept many years back, right? But I'm very happy that, the concept is now catching, data is now catching up with some of these early ideas. The bad aspect of diabetes remission, and this is, I think, very important. Fundamentally, we forget that why are we treating this disease in the first place? We are not treating this to get patients rid of medication. That is not the aim. The aim is to prevent micro and macrovascular complications. Now, if the patient can prevent micro and macrovascular complications with the use of SGLT2 or with the use of GLP, why not? Why not consider giving them those drugs instead of just focusing on removing the drugs? So removing the drugs should not be the long-term aim. And this is what Dr. Kalra also said in his paper. The fundamental goal of diabetes remission should be to prevent long-term diabetes-related complications. I should not go away from the target. The target is to reduce complications and not to reduce medication. This is where I fundamentally differ with all these studies which were published, especially the twin health studies and all the studies, where they say, oh, we reduce the medication. No, reducing the medication is not the aim of any treatment. The aim of treatment is to reduce complications. And if you are able to prove to me that by your twin health or by any study, you are able to reduce the complications, which some of these studies in their defense have shown, then it is an attractive idea, right? Again, you also have to prove to me that this reduction of the complications is better than existing gold standard, which are medical management. So if your therapy or if whatever innovation that you have done is able to reduce the risk of heart disease, able to reduce the risk of kidney disease, able to reduce the risk of other microvascular and macrovascular complication of diabetes more than the drugs which are available to the patient, like the SGLT2 inhibitors or the GLP-1 receptor agonists, then your therapy should be the gold standard and not these drugs. However, if your therapy is inferior to SGLT2 or a GLP-1, then SGLT2 and GLP-1 should be prescribed and not your therapy. And this is the fundamental core thing you have to understand. If you do not understand this, I think this is where the problem lies. And then comes the again. I have seen, I was going to, sometimes things make me so angry that I was actually going to put the screenshots of some of the really, bad commercials by certain companies about diabetes remission, diabetes reversal, and whatever nonsense, right? I beg of you, please do not refer your patients to any of these policies which are completely, I will not name them. I'll refrain myself from naming these, right? Because the sanctity of the platform. But the point is that there are companies in India who are continuously misguiding the patient about diabetes remission. I have seen one ad, and I'll name the actor, is Boman Irani. I saw this completely ridiculous ad by Boman Irani regarding one company. Again, I'll not name the company, I'll name the ad. I'll tell you about the ad. In this ad, Boman Irani is sitting with a plate full of some very tasty food and a jar full of a glass full of what looks like a cola, and says that, oh, I can't eat this, I can't drink this. Not anymore. You get into this program and then you are able to eat and drink this. Complete nonsense. Like I said, we started this entire talk from the very fundamental point that diabetes remission does not mean that the patient can eat whatever they want and can drink whatever they want. They cannot. They cannot, because if they do that, remember, like I said, the ice can melt, the water can turn into steam. It doesn't take time for them to go back to the situation where they were. So there is no miracle cure. I have also seen ads where there is company who said, "Oh, my HbA1c was 8.5, now it has become 7.6. My diabetes is reversed." What nonsense! That means you don't even know the definition of diabetes remission. So please, I request you, all for the companies who are doing this, please stop doing it, right? And for the doctors who are there, and I think it's high time that you push back on this. And then it's for the patients, again, please do not waste your money on this. Some of these programs are so expensive. There are it is a money well spent on other things, right? Please don't completely waste your money on these things which have absolutely no fundamental basis. Finally, some take-home messages. So, first take-home message is in the name. It's diabetes remission and not diabetes reversal. Second important take-home message is that type 2 diabetes remission is possible in certain patients with type 2 diabetes. But what you have to do is you have to restore the balance between insulin resistance and insulin production. Thirdly, you have very well defined criteria for remission, where we said HbA1c should be less than 6.5 for at least 3 months without glucose lowering medication. And we said that weight loss and early intensive insulin therapy are proven strategies for diabetes remission. And finally, we talked about the good, bad, and the ugly. That is, the good part is that this actually motivates the patient to do well. The bad part is it often takes that our target away from what actually we are trying to achieve. Ugly part is that there are clear push by some of these people, some of these companies to scam people, unsuspecting patients, and we should probably be refraining from that, right? And finally, it's an area of active research. There's a lot of scope for this in this area, and again, young researchers interested in this, I think, should be really taking this up as an area of research, because it is very important for the patients to really, from the patient's perspective, this is very, very important, right? So thank you for the patient listening, and now we'll be happy to take questions which are there on this.
Wonderful question. We do have a lot of questions coming in from our doctors. It's from Dr. J.S. Desai. Says define remission.
Well, I think we defined it several times during the talk, right? So HbA1c less than 6.5%, without use of anti-diabetic medications for at least 3 months is the current definition of diabetes as given by ADA consensus. There are alternative definitions also, but that's the current definition as per the ADA guide.
So moving on to the next question from Dr. Pankaj. So instead of insulin resistance, can we add insulin sensitivity for the balance between insulin sensitivity versus insulin resistance versus insulin production?
Yeah, it's the same thing, right? So insulin sensitivity is opposite of insulin resistance, right? So higher insulin resistance meaning less insulin sensitivity, and vice versa. So whatever term works for you, it's fine.
Next question from Dr. Kumar. If the fat in pancreas and kidneys can be measured?
Yeah, it can be. So there are, again, it's a large topic. So we have a talk on, you can search for it. We have a talk on, in fact, we have notes also on, we have this Endocrinology India, notes in endocrinology sessions. It's endocrinology.co.in. There you can search for our, notes on non-alcoholic fatty pancreatic disease, where we have talked in detail about how to measure the pancreatic fat. So there are certain MRI, protocols which you can use for measuring pancreatic fat. Of course, gold standard will remain a biopsy, but you're not going to do biopsy for routine patients. So there are certain MRI protocols, and there are certain nuclear medicine PET scans which can also measure fat in the kidneys. So there are ways in which you can do that. Though they are more difficult to measure compared to liver fat, which is liver being more easily accessible from a visual point of view. So it's much easier to measure that. But there are ways in which you can measure. And in fact, Dr. Roy Taylor himself has done several studies where they actually done biopsies also of patients where they looked at pancreatic fat. And that is where they really came up with the idea that pancreatic fat reduction actually leads to diabetes remission. So I was saying, non-alcoholic fatty pancreatic disease, we had given a talk on this in one of the some of the lectures somewhere else. So you can have a look at
that. So moving on to the next question, that is another one by Dr. Kumar. If you could talk more about meal replacement, please.
Yeah, so you can read the entire direct study. So where they used a proprietary formula for meal replacement. So what they did was they're basically protein shakes. I think similar products will be something like Ensure Diabetes or Protein X Diabetes in India, there are many other powders like that. So Glucerna and all that. So there are many others available worldwide. So what they did was that they started replacing one meal with this liquid, you can say milkshake or shake or whatever, protein shake. So they started replacing a lunch with that, then snack with that, then breakfast with that, dinner with that. So that is what ultimately they did, because the strategy was that they it should lead to weight loss. So that was the whole idea. So that was how they did in terms of the direct trial. So it's not, see, the problem with direct trial is it's not possible to do it in real life. You cannot do that. But what we learned from the trial was that weight loss leads to diabetes remission. So if you lose weight by some other means, great. I mean, you need not do meal replacement, right? But meal replacement is one known strategy. So what they wanted to do was, without medication, without surgery, they wanted to see how you can do weight loss. The only strategy which was feasible was meal replacement.
So moving on to the next question
Yeah.
from Dr. Khanna. Giving an insulin function for 21 days in intensive and a GLP together for obese, can it provide more better remission?
Yeah, 100%, right? 100% they can. So, but having said that, what happens is, uh, in my opinion, you should do it sequentially, not together, right? Because the pathophysiology at different states is different. So what I will do is, this is the early intensive insulin therapy studies were done before GLP era, right? So what if I have to do this study again? What I'll do is, for 2 weeks I'll put the patient on early intensive insulin therapy, and after 2 weeks I'll switch this patient to GLP, right? So and then that, obviously, that by definition will not be remission, but I think that is the perfect way of treating the patient, right? So because initially the patient will be glucotoxic. During that glucotoxic state, giving GLP is actually going to be counterproductive, and it's not going to be helpful. So in that initial 2 weeks, you rather give insulin. After 2 weeks, you switch the patient to GLP, and then maintain the patient on GLP for a long time. So that is, I think, a very good way of a modern way of treating diabetes. Unfortunately, it is very sad to say, the ADA and all that, they don't have, I think, the lack of imagination. They're all stuck with the old ways of managing diabetes, right? Which I think is now far outdated, right? This thing of adding metformin and then adding the second drug and third drug, completely outdated and wrong way of managing diabetes. Some of these other strategies are actually better, right? So what you said is actually a right way of doing the things, right? So patient comes early on, patient is glucotoxic, you give this patient insulin, and then once the patient is, stop the insulin, once the patient develops euglycemia, stop the insulin and then give GLP. That will be a better strategy.
So next is from Dr. Walmik. Can we use multiple injection with long and short acting?
Yes, of course you can. That's called multiple dose insulin strategy, right? That is exactly what they did in the early intensive insulin.
Dr. Panchani says HbA1c less than 6 for at least 3 months means 6 months because we do it at interval of 3 months.
I didn't understand the question.
Dr. Panchani, if you could elaborate on that, and we can take the next question till then. Next is from Dr. Surya Prakash. Does TIR help in remission of type 2 diabetes mellitus?
Yes. Well, time in range is, so if you're able to achieve excellent time in range early on in your treatment, these patients are more likely to develop remission. Of course, there are no well-established studies for that. But again, as an expert opinion, I'll say yes, right? So if the patient has good time in range, you are, more likely to develop remission for sure. So if you have a patient, you start them on therapy, and apart from getting good glycemic control, if the time in range is perfect, right, you achieve almost 90 to 100% time in range. Difficult to achieve, but it is done. I have patients with CGM will show you 100% time in range, right? Such patients of mine, I can say, I tell to the patient that you have done very good, you will go for remission, and they do, right? So though unpublished expert opinion, I'll say yes, it's a very good parameter to really see. If I have a patient on treatment where I put a CGM and I find the time in range is 100%, 90%, these patients are very likely to develop remission. Of course, there are caveats to it. Caveat being that patient does not have any beta cell defect and all that, but generally the routine garden variety type 2 diabetes with 100% time in range, these patients should be considered for remission because they will.
Dr. Shah asks, would you recommend remission in patients of type 2 diabetes mellitus with BMI less than 25?
Yeah, so the concept, is, so I'll say yes and no. Yes, because we all know that BMI is not the perfect marker of ectopic fat, right? So a patient with a BMI of, let's say, 23 and has higher ectopic fat, yes, you should consider remission. Why not, right? Having said that, if you see all the clinical studies and including the all the trials, obese patients were more likely to undergo remission. So younger obese patients are more likely to have remission other than older, thin, leaner patients, because a leaner patient will have often a different pathophysiology. So if you have a patient with BMI less than 25, and if the patient has proven type 2 diabetes, right, and doesn't have any other secretory defect, yes, the patient can undergo remission, and you should consider, if the patient wants it, you should consider going for it.
So there are some similar questions. I'm addressing it together.
Sure.
So next is from Dr. Purohit. After how much weight loss patient can reduce the anti-diabetic drugs?
Yeah, so like we discussed, see, any form of weight loss reduces anti-diabetic drugs. So we say if we go backwards, right, 15% or 15 kg weight loss, you're off the medications. Maybe if you do 10% weight loss, you might be on a 1 or 2 drugs. Maybe 5% weight loss, you will be able to reduce some of the drugs, right? So, it will depend from patient to patient, but the point being that, it's directly proportional to the amount of weight you lose, right? So if you lose more weight, naturally you lose more medications also. Having said that, some of the medications themselves produce weight loss. So on stopping those medications, there will be weight regain. For example, if the patient is on a SGLT2 and you stop the SGLT2, the patient can regain weight. Patient is on GLP, stop the GLP, patient can regain the weight. So that is what you have to be careful about. And then when you're stopping the drug, the patient has to be told that if I stop this drug, then you have to double down on your lifestyle measures, because if you don't do that, you'll regain the weight. And if you regain the weight, you'll go back to where you were. This has happened to a lot of my patients. Trust me. We have reached remission. I'll tell you the classical definition of remission. If you see 3-month therapy, we have several patients. In fact, we have probably as many patients as a lot of these international studies have. The problem is, I'm sure the same international study, see direct trial, 5-year follow-up. Most patients, get back to where they were, right? So the problem is that achieving something is fine. Are you able to maintain it? That is even more difficult, right? So we have a lot of patients who have undergone remission, who have stopped medications for 3 months, 6 months, 1 year, 2 years. But after that, if they are not careful, right, they go back. And sometimes, patient is on one drug, maybe a SGLT2, because generally SGLT2 or GLP is the last one that I remove, right? If the patient is on those drugs, you stop the drug and you tell the patient that you have to be very careful, double down on your efforts. That patient doesn't do that, you go back to where they were. So it's a challenge, right? So it's a human tendency that we jeet gaye, abhi, we are relaxed. It's not like that. That is exactly why I very much dislike the ads where with teachers, Boman Irani, where he exactly says this, which is completely wrong, right? The purpose of diabetes remission is not that aapko jo khana hai khao, jo peena hai piyo, right? In fact, if you undergone remission, you have more, like you have to double down on your lifestyle measures. Otherwise, you'll go back to where you were, right? Trust me on this, right? So you can't have your cake, literally, you can't have your cake and eat it too. That's as simple as it is.
Next question from Dr. Kiran. Can remission be achieved by diet and all medications like metformin and glimepiride?
Glimepiride, 100% no. You put the patients on SUs, forget about remission. Okay, remission, I already said, in my talk also, the old style of, pushing the pancreas and SUs, no, right? If your patient requires a sulfonylurea, right, the patient is unlikely to undergo remission. Take it from me. Metformin in itself will not produce remission, right? Metformin is produce very modest weight loss, not much. But if you combine it with the lifestyle measures, yes. So if the patient is on metformin and patient has lifestyle measures which is intensive, yes. Patient on pioglitazone and lifestyle measures are intensive, yes. But patient is, just because of metformin, patient goes remission? Answer is no.
Dr. Agarwal asks, in lean-thin type of type 2 diabetes mellitus, how to get rid of fat in liver and pancreas?
Even in those patients, it is the same thing, weight reduction. So unless, like I said, remember the pathophysiology. If your patient is a classical type 2, like the kind of patients we saw in direct study, their pathophysiology is the same, whether they're lean or whether they're obese, does not matter. It's the same fat in the pancreas which is causing a problem. Having said that, there are other patients who have other pathophysiology involved, which we often do not know. Some of these patients have actually, some form of malnutrition-related diabetes like FCPD and all that. In which situation there is a different pathophysiology, and in that situation you are not going to go remission. So, if you have a lean patient with pancreatic and liver fat, the patient will undergo remission if you lose weight, and even if they are lean, you have to still reduce the weight, right? If the patient is BMI of something like 22, 21, right? You still have to lose the weight. If the patient has a BMI of 18 point something or less than 18, then probably patient does not have type 2 diabetes. That is what you have to understand. Such a patient is more likely to have some other form of diabetes, probably malnutrition related diabetes, maybe some other form of diabetes, right? So you have to be careful in that.
So Dr. Panchani has elaborated the question. For remission, we take HB1 AC less than 6 for 3 months. We say it is remitted. But do we need to do it twice, at third and at 6 months, or only one reading of HB1 AC is sufficient to say that diabetes remission has occurred?
According to the definition, one reading is enough, right? According to the definition, one reading is enough to say that currently the patient is in remission, right? So let me put it this way. Let's say patient comes to me, right? Patient is doing very well, losing weight. Patient is on some last drug, right? Patient is on metformin. I stop the metformin and I call the patient back after 3 months, right? Now, when the patient was on metformin, his HbA1c was 6.4. I call the patient back after 3 months. Patient is still having HbA1c of 6.4. Now, that means for 3 months, the patient was not on any anti-diabetic medication. HbA1c is maintained less than 6.5%, and patient is, maintaining the situation. So, by definition, he has had remission for the last 3 months. Now, whether that will continue for the next 3 months, I don't know. It depends on the patient, right? But at least for the 3 months, patient was in remission. That's the point.
Next from Dr. Ashish. Premix versus basal bolus regime, which is more suitable for achieving remission?
Okay. Again, I have very radical ideas on these things. Premix insulin is not suitable for anything, right? It is not suitable for any form of diabetes. So, if the studies which we are talking about were about, either they were using insulin pumps or they were using multi-dose of insulin, which is basal bolus insulin, not premix insulin. Okay. There is, like I said, a very early study done by Dr. Rakesh Sahai, not the senior Dr. Sahai, who actually looked at using premix insulin in some of these patients, and they actually had some remission. We don't know long-term data. I don't even remember the study. It was published in JAPI many years back, before my time. What I'll say is that they had done it, but subsequently, I am not, somebody talked about time in range. You will not achieve good time in range with premix insulin. So please do not expect much from premix insulin. Premix insulin are shortcuts, right? They're only for those, patients who don't want to take multiple shots or some, other ideas which we had about premix. In modern therapy, co-formulation insulin is different. Premix insulin doesn't have much role in modern medicine, right? So if you're talking about remissions and all these things, premix doesn't have much role. Sorry to say. Premix insulin are very, if you put CGM in your premix patient, take your premix patients, very few patients will have very good time. They will be hypers and hypos and hypers and hypos all the time, right? And such patients, who are having so, fluctuating diabetes are never going to undergo remission. You need very smooth control for the patient to maintain good glycemic control, and then only then the patient will undergo remission.
So is it okay if we take the last 3 questions for tonight?
Sure, absolutely.
So the next is from Dr. Kumar again. How to salvage 40% of beta cells at the time of diagnosis?
You can't salvage 40%. You can't, right? At best, you can salvage 5 to 10%. And that is how the strategy for doing it is early intensive therapy, which does not include sulfonylurea. Trust me, right? No SU. So, early, newly diagnosed patient with diabetes, give them all therapies other than SU. Try to achieve excellent glycemic control. in a very short period of time. Try to maintain good time in range, and then you'll achieve remission, right? And then you'll salvage 5 to 10% of the pancreatic beta cell. You can't salvage 40% of pancreatic. It's not possible, right? Already, some of them have undergone, amyloidosis, amyloid deposition would have happened. They've already got permanent damage. You can't recover that. You can only recover 5 to 10%, and that, trust me, even that 5 to 10% is often enough to achieve equilibrium, provided the patient also has lifestyle measures. So if you salvage that 5 to 10% and the patient undergoes lifestyle measures, you've done a good job.
Next is from Dr. Gupta. Can SGLT2 inhibitor be the first line therapy in type 2 diabetes?
Yes, it can, right? But we are still, like I said, stuck in the past. Problem with SGLT2 inhibitor is not that you cannot prescribe it to anybody, right? It's not a very universal drug. You have to be selective in which patients you give SGLT2, in which patients you don't give SGLT2. So it can be first line therapy if you know what you're doing and if it's the right candidate, right patient. But there are certain situations where you don't give SGLT2. Maybe we can have that as a discussion in some other talk. And we in fact had one earlier on with some panel with Endocrinologists and Medflix. You can probably search for that where we did talk about this. So right patient, yes. All patients, no. That's why probably it cannot be a universal first line therapy. I would say in future, when GLP becomes cheaper, it will probably become the first line therapy for diabetes. It will replace metformin. SGLT2 a little difficult because SGLT2 has a lot of problems associated with that. It comes with a baggage. So unless you prescribe it to the right patient you give it, fantastic results. But wrong patient you give it, you end up in trouble. Metformin you can generally give it to most patients, right? But SGLT2 is not that universal.
So, taking the last question from Dr. Jayashree, the semaglutide is useful in remission.
Yes, absolutely. Right. We did not talk about this, but by classical definition, patient should be off semaglutide if you want to say the patient is in remission. So classically, it is very difficult. See, because what will happen is the patient loses weight because of semaglutide. Patient will go into remission. Patient will develop good glycemic control. You stop the drug, patient will maintain remission for some time, but start regaining the weight again. And then eventually go back to where they were. So if the patient is just on semaglutide and continues that for a long time, patient will maintain remission. That is probably the best way, and that is the future of diabetes management. Trust me, the future of diabetes management is GLP, right? So though technically it will not fall into the definition of remission, patient will maintain good glycemic control, prevent complication, prevent cardiac disease, right, with semaglutide. But if you talk about the current definition, which it's still a Darwinian definition, there's no logic for it. Please don't ask me why 3 months, because some studies have used 3 months. It makes no sense. Ultimately, that's why I said the point of therapy is not to stop medication, to prevent complications. So a sensible strategy is that if the patient, you stop all the drug and patient is just on a semaglutide and is maintaining on semaglutide, that's the best thing you should do for long term, right? Stop all the other things, just keep the patient on semaglutide for a long time. You've done a good job.
So there's just one last question, if it's okay with you. Can we take it?
Sure.
Yeah. This is from Dr. Sunita. HbA1c 6.2, but fasting sugar is 160 for 3 months. Does it mean remission or not?
Well, that means that your HbA1c is incorrect, right? There could be other factors which are leading to a false low HbA1c. If the patient has fasting blood sugar of 160, I'm assuming that the post-meal sugar is 180, 190. HbA1c cannot be 6.2, right? So that means either sometimes patients have hemolysis, which can reduce false low HbA1c. Sometimes patient could have variant, some hemoglobin variant, which can lead to low HbA1c. So theoretical question, answer is again, there is no thing, but such practically it is not possible. If HbA1c is 6.2 and fasting is 160, and we are assuming that it is properly done, then there is something wrong with HbA1c or something wrong with the fasting sugar, right? Something, because it's a discordant value, right? So practically less likely. One of the values has to be checked, right, and rechecked. So yeah.
So thank you for taking in the questions from our doctors. With this, I would also like to mention that there's a lot of appreciative comments coming in for your sessions from our doctors. Thank you once again for this session. Doctors really seem to have enjoyed it, and they have been asking their questions. And thank you once again, sir, for this session. We really hope to see more of you on Medflix. Thank you once again, sir.
Thank you. Thank you, Masha. Bye.